came with all this in one patient or somebody, and the whole totally a crippled joint, they were literally written off, even as late as about 20, 25 years ago. I mean, it would take a Herculean task to reconstruct these complex situations, and they were more or less bound to the wheelchair. Both on the medical front and on the surgical medical front, we had the drugs which probably could give them some remission, but not at this stage. So this was a huge challenge, but then we have come a long, long way in this, especially dramatic changes that have occurred over the last 25 years. The second dilemma we face today also is the patients who present like this. And this was a lady who presented with this sort of a pictures. And when you see her walking, this was totally a disproportionate type of a gait for this type of a knee joint. And then I kept probing, and then she didn't come with any history that was forthcoming till she dished out a bunch of papers in which she was having. And it said this was a rheumatoid disease. And she had been on some treatment for 10 years. Subsequently, they were put on Polytrex, she didn't take, thinking probably this was a steroid and she didn't want to add up with it. So clearly, probably she was having a debilitating sort of inflammatory arthritis, which had been gradually progressing, but not rapidly deteriorating, basically because she has been subdued and sort of some suppression because of the medication she has been on. At the same time, probably a secondary osteoarthritis of the knee has also set in. So primarily, probably here we are seeing a super addition of both inflammatory along with the degen sort of a situation. So I think the presentation patterns, the symptoms, the classic features still form the core of the diagnostic cascade. There's no question about it. But what is very imperative for all of us as clinicians is to clearly put forth what is degenerative, what is inflammatory, because this has a great significance. Because if we look at the therapy and the treatment, the diagnosis and treatment will follow a very different and divergent path if it is going to be degenerative or if it is going to be inflammatory. It's very, very obvious, no great science in this. And this is where I think the question comes, how early can we pick up? The earlier we pick up these the problems and diseases, I think the better we are with regard to the therapeutic options. We can probably put them disease-free, we can put it in disease suppression, at least not let them, most of them, go into debilitating situations like you saw on the X-ray in the first. But the ground reality is very different. If you look at it, everything is branded and bandied as arthritis. Whatever sort of the picture, whatever sort of the deformity you put, generally they say arthritis, they come. And some of them hidden in this subgroup, some of them probably are inflammatory and they totally get missed because they are just looked at differently. So just talking about a few basic words about what really are we dealing with? What is so much about this inflammatory arthritis? Classical word inflammare, it is a Latino word, which is just to set things on fire. So this inflammatory arthritis basically sets the joints and the joint tissues, some of the connective tissues, into a significant degree of destruction and secondary functional debilitation. So this essentially is a process whereby the body recruits any sort of defense in our body systems to infection or inflammation or some sort of a foreign onslaught is release of lymphocytes, which then sort of releases the complex proteins. It may be cytokines, maybe these chemical messengers, which are more and more are being picked up. Disease-specific mediators are being picked up, and these sort of take care of the whole situation. So that is basically the inflammation, which is a normal response of the body to any sort of foreign onslaught, something from the outside. But when you talk of inflammatory arthritis, it is clearly a situation where we find that the body fails to distinguish from the good from the bad, from the self to the foreign. So it doesn't realize or distinguish between the foreign and the self substances. And so what happens is in this, the immune system of oneself or our own immune system goes wrong or rogue, I would say, damaging your own body cells. And this is sort of a little paradox, but that's what really happens in some unfortunate group of people. Those people lack the individuals lack the ability to self-regulate, and the protective system becomes the one that destroys the patient himself. So that is the situation, what we call as the inflammatory arthritis. What we can say is autoimmune disease, your own immune system fighting against you and not fighting for you. And when you have this prolonged activity of these having progressively maintaining, sometimes at a low pace, or sometimes it increases depending upon the severity, It can manifest in various levels of severity. So far as the articular joints and the systems are concerned, the synovial inflammation leads to proliferation, effusion, synovial pannus formation, and the cartilage slowly destroys. For example, in this stage, if you find there's minimal cartilage destruction, but the pannus and there's a significant amount of a proliferative synovitis. All these are going to keep on secreting the poison. When I say the poison, the cytokines and other structures, and they start permeating into the cartilage. And over time, you start finding significant ulcers, destruction. Medical therapy would arrest this to a great extent, at least postpone it to a long time. But if it doesn't, it rapidly grows. And in some, even despite the good medical therapy, this can happen. And finally, a sort of secondary changes start setting in because there's hardly any cartilage. It's a bone-on-bone situation. And then it is a mechanical problem superimposed over the autoimmune disease. In terms of diagnosis of this inflammatory arthritis, sometimes this diagnosis to put a finger to the specific disease at hand can take days or weeks, and this becomes very overwhelming to the patients. One, these people are in pain and agony, and the anxiety and the concern also grows whether they are dealing with some crippling disease. They have some partial information. As physicians, till we get all the reports, we are not able to sort of definitely tell them the diagnosis. So they need to go through the hematology, serological investigations, and any depending upon the need base of that patient, or probably the physicians may add a variety of scans, sometimes even a PET scan. So these all take time sometimes. At least fortunately here we're able to do it rapidly, but then the patient needs to wait till this point. I don't want to dwell much on these investigations because that is Dr. Alap's domain, and probably he'll be giving a much more clarity on each of these issues. Broadly, if you look at it, we do the serological, hematological investigations. Sometimes the aspirates of the joints also go in for assessment and then to see for the chemical factors and the other things which can be picked up. Serum uric acid, if it is gout or some other sort of a disease, again, one can pick up again from the hematological sort of profiles. But basically, one thing you find is in most of these cases, you'll find the basic SED rates and the CRP elevated in all these cases. And the need for doing sort of imaging studies on this mainly is to see if there has been any sort of the cartilage issues or if there is a subtle synovitis, which again gives us some clue as to which direction we need to proceed. And this power and ultrasound may also help us to sort of pick up a focal sort of a loculated synovial fluid if we need to assess and aspirate for this. Gout is another type which you know it is basically because of the gouty crystals, inflammatory disease due to the excessive uric acid. We have easily picked up, monitored, and the surveillance can be done with your blood investigations, a purine breakdown product essentially. Well response again to the medical treatment and of course some dietetic modifications which are commonly advised to most of them. For some strange reason, like you all know, it affects the great toe. And over a time, of course, you can find the gouty toe and the gouty arthritis, even in the other joints. Like, for example, you can see in the wrist, you can see in the knee, and other joints also. But one thing is, I think the people to keep out of remission require long-term drugs and dietary modifications. This is something which is, again, a very early presentation, which I thought we should bring forth to it. Quite often we have these people who present with a diffuse sacroiliac pain at the low back, often written off as a back sprain, backache, and they are put on just standard medications and physical therapy. But this can masquerade as a pain in the back, but really being an inflammatory disease. And one needs to be aware of this because certain combinations in certain type of patients with certain other histories, basically involvement of other joints or other systems can put a pointer to an inflammatory etiology. This could often be the first zone. For example, ankylosing spondylitis. People are moving well, people are walking well. We think this can't be. Not every ankylosing patient needs to present you with a stiff joint, and they present with sacroiliitis. And conversely, when in a frank ankylosing, you take the X-ray, you find a fused SI joint or a highly sclerotic SI joint. So I think we need to be aware of it, like we see on the X-ray. These are the early pictures. The hips are fine, but he's developing the angular sacroiliitis, and his serological markers were positive. The B27 was positive. Talking about the serology again, which of course the our next speaker will be talking about, 50% of the angstpong will have the HLA-B7 to B27, but 10% of the population are positive for this without having a disease. So it is not that on average, even if you take a random survey, 5 to 8% do show the gene. They don't probably manifest the gene. A positive gene without symptoms, it is not diagnostic. So somebody you do and suspect, it does not mean that in future they're going to develop this. They may not develop. So it does not mean that every HLA-B27 is angstpong. There are sometimes women who come with, it is not a male dominant. We also now have enough ladies and women who present with this. This is something which we very commonly treat sort of when we are very at a loss as to what it is. We call it a reactive arthritis. But oftentimes what we find is more often it's a viral sequelae. That is very commonly we find this. And also additionally, we also may find post-infective focus anywhere else in the body. Just in point in note is in the recent times, in this era of the COVID pandemic, there have been 3 to 4 cases which we ourselves have seen where subsequent to a viral response, the hips have got fired completely. And 2 of them have undergone replacements. But the strange part of it is they presented as an articular infection first, as a viral response, and subsequently became secondary arthritis. But in most other situations, I think these reactive arthritis essentially require supportive care and observation. Refractive, though no other issues, often self-relating. And essentially, most of the time, they end up with this diagnosis as a process of elimination when you rule out most other likely possibilities you are concerned about. Now, polymyalgia rheumatica, again, another disease which mimics a late onset inflammatory arthritis, predominantly a late decade problem. Elderly presenting with sudden stiffness and pain is one another group where predominantly it can mimic also something like a picture of fibromyalgia. And muscle groups, multiple muscle groups being involved in complaining of pain, the joints and all over, shoulder, back, thigh, and wrist usually are the very common. Commonly manifest in the morning as a stiffness, and they are associated in about some percentage with associated temporal arteritis. So when we watch out for this, when other things are negative, again, this could be treated symptomatically, response is very good. So inflammatory arthritis, just to add up, I think may have a complex situation. More often they may present, multiple patterns can present together. For example, a simple point in reference to rheumatoid with a Sjogren's, where we have the keratoconjunctivitis sicca. The potential to start with the one type of an arthritis or inflammatory disease and progressing to multiple, ankylosing spondylitis or psoriatic arthritis, later on presenting with ankylosing spondylitis. All this just goes to show that when we now talk about the treatment, we have to emphasize that there's a comprehensive need for a comprehensive sort of arthritic care so that every aspect of it is looked into. Some other pointers when we talk about inflammatory arthritis in terms of the clinical diagnosis and the disease approach is we usually divide them either as inflammatory or non-inflammatory. Either the onset is acute or chronic. Most of the times, it could either be an acute presentation at the beginning or sometimes a subacute to chronic. Most of the time, it can also be a monoarthritis, poly or polyarthritic, like I mentioned before. There are some patterns which are female predominant, some male predominant you'll see. Of course, juvenile diseases are pretty much lethal because they have a very sort of a significantly debilitating case as it progresses. But also we have seen that later in life, these inflammatory diseases manifest, the less severe they are in terms of the clinical manifestations. Presence of extra-articular features one should look for, like uveitis or the connective tissue disorders, I think very, very important. For example, if you look at the psoriatic arthritis, any joint can be involved. But on the other hand, if you take rheumatoid arthritis, it is strangely predominantly the proximal and the distal proximal interphalangeal joint and the metacarpophalangeal joints which tend to get involved, never the distal interphalangeal. The distal IP joint seems to be a domain of the osteoarthritis, where we don't find any MCP joint involvement. These are predominantly observational in most situations, but of course there may be exceptions that may exist to us. Rheumatoid or SLE for that matter, they are symmetric, bilateral involvements, quite often, which is seen. Asymmetrical joints, psoriatic, will find only a monolateral involvement in these cases, or the reactives maybe. Sometimes you can find the axial skeleton involved, the spondyloarthropathies, ankylosing spondylitis, reactive arthritis, like we mentioned. So I think the symmetry also speaks some direction about which way to proceed in these cases. Now let me spend just a few minutes upon the care of the inflammatory arthritis. I think one situation we have realized well that the orthopedic surgeons or the surgeons in general should take a back seat. At our clinic, again, here, we never do the medical management of the inflammatory arthritis, totally dealt with by the medical rheumatologists. The prime caregivers in this group of problems are the rheumatologists and the others with focused interest, people who are more into treating the autoimmune disorders and the other people. Some important aspects about the treatment of these today is the newer approach to therapeutics has proven to be highly effective. The biological therapy or the biologics have come to the fore more and more. The cost still is a challenge. The surgeons come in only at the end stage disease when the disabilities sort of manifest themselves. Corrective surgical possibilities today are immense. The options are many. I don't think there are very, very few situations where we don't have any sort of option to correct it with our resources. And appropriate care really enables them a near normal living. So most centers and most places organized in the bigger centers, you will find we have the combined arthritis program. This is what we have initiated here with us, which involves both the physical therapist, a psychologist, and a counselor, a rheumatologist, and then the surgeon. This helps us to sort of appropriately position the patient and not delay any treatment, because concurrent approach makes it sort of the study, the surveillance, and the follow-up of the patients much, much better. So a sort of a collaborative care seems to be the order of the day. And wherever you, even internationally, anywhere else, that is the approach that's taken. So the mainstay, like I mentioned, is the medical rheumatologist who is in the lead. The rehab group, pathologists, psychologists, and lastly, the surgeons come together, because our requirement as a surgeon comes in much later in the process of the disease. So now, half the time we just put them down in the gym where they're assessed, they're suggested, they're counseled, they're rehabilitated. I think that goes a long way in all this thing. With regard to the drugs, the conventional therapies, I think common initially at one time, it was predominantly the non-steroidal anti-inflammatories. We used to continue them on indomethacines, sometimes a bit of a sulfasalazine, and pulsed steroids. This has taken a turn today. I think there are much better options available which the rheumatologists adhere to. The steroids, for example, today are essentially used, one, in the very early acute phase to reduce inflammation, or also it can suppress the immune system to a great extent. So, but often these are used only for a limited duration. In extreme cases, maybe a very low dose for a protracted period to control the flares. They are also used in the topical forms, intraarticular injections, or in focal areas of pain and fibrositis. To give steroid injection is not at all uncommon, though sometimes patients tend to be very skeptical, but it is for us to talk them out of it. The only downside is, I think, concurrent treatment of the potential osteopenia and the infection susceptibility needs to be drilled into the patient, and our medical prescriptions should involve concomitant therapy prescriptions for these things. Current options in therapies broadly can be divided into the synthetic DMARDs and the biological DMARDs, disease-modifying anti-rheumatic drugs. Methotrexate, sulfasalazine, and leflunomide are very commonly used in most rheumatoid patients or most inflammatory patients. You would find them used even in psoriatics for that matter. But the biological disease-modifying drugs are more to the fore, like the tumor necrosis factor blockers, interleukin-17 inhibitors, phosphodiesterase drugs, and many more. These are target-specific. They have been designed for specific diseases. You have specific different drugs. I don't want to go through the names. So the disease-modifying rheumatoid drugs, basically what they do, they retard the process or they modify the progress of the disease. They have been very effective, like I said, in very many inflammatory disorders, but they have to be on the long-term therapy, often given as in injections or infusions, and then subsequently they continue. But these tablets can be enable a remission for quite a long time. And when they are in care, I think one has to also constantly monitor and do a surveillance of the renal and the kidney functions. Initial response may be slow, but subsequently, with compliance to the drug treatment, the results are quite prolonged. Biologics, like I mentioned, again, action is faster, target specific proteins involved. So for every disease process or the specific rheumatic disease process or the inflammatory process, the drugs differ. Most biologics are basically proteins and so delivered again as infusions. There is significant improvement in prognosis and function, which is again seen. And compared to traditional treatment, they have come out as far better. But one impeding factor is predominantly the cost, which is an issue, and the immunosuppression which goes along with it. I think one needs to be careful, and it is a sort of a small challenge in the management. So they need to be under constant surveillance of a rheumatologist all the time. So like I said, treatment-specific targets for the rheumatoids or the psoriatics, we have various types of the blockers, like the TNF-17 and the IL-17 for psoriasis, or the TNF blockers for spondyloarthropathies. So in short, if you look at the options available for the medical management and the comprehensive care, all is never lost. There are collective solutions that exist, like for a lady like this, also for almost all situations. We can do both. Together with the medical therapists and the surgeons together, we can deliver them and put them back on their feet. Another case, an example here, she's again both knees, both hips. She's got one shoulder done now, and then she's now the finger joints have been taken care of by the plastic surgeons. So I think we are able to put them pretty much functional, and it is not thing. Often the question comes, do all the alternate treatments are effective in this case? I think I would personally say yes. The reason is, I think none of us are gods. What the rheumatological medications, what the rehabilitation surgeons can offer is one part of it. But the second part of it, these alternate therapies, which are essentially in the form of sort of, massages, the stretches, treatment, they do maintain, because a lot of these rheumatoids, in fact, the lady on that stretcher is with all the four replaced, but every year she goes to this center in Kerala and comes back after 2 months. And I think I look at it as one, these are age-old traditions. There's a significant feel-good factor, and who doesn't want to spend time in these ambient places for a month or two? It's more like a holiday relaxation. I think it is a bundle package with everything put together, the environmental impact, the massages, the rehabilitation, and everything. So I think we should probably at some time encourage these patients also to take these sort of breaks wherever there are many more which are mushrooming all over the country. I think these are useful. Second, I think aspect which is less talked about is also an important fact that one needs to have a psychological counseling with regard to motivation and self-drive. I think this is some of the patients who do extremely well. You do the same thing to somebody else who doesn't do so good. That is because the motivation and self-drive of the patient and the care team. And if they feel there's a team that is with them all the time, I think it improves. That's where I think group sessions and the therapies score, the serial follow-ups and documentation help, and information and discussion on all possibilities in the future tools. Once they know what to look for, what to anticipate, it helps a lot. And at times, I think this needs to be driven with the psychological help. So far, the big bottlenecks to comprehensive care is concerned, what we realize is compliance. Frustration because the response is poor. Sometimes overprotecting family who refuse to let them do this, do that. I think what is important is for us to push them to do all normal things. And let them follow and go over the obstacles and carry on as normal. And of course, the social stigmata and issues sometimes could be an issue. So I think medical mainstay happens to be the main treatment along with the rehabilitation. We all come again, this is this lady. The current medical therapies, especially biologics, the rehab protocol, and the various surgical possibilities and options for correction in advanced stages enables us, we the physicians, to put them back to where they belong. And this is the lady a few days after the surgery. The food gets cut and everything gets corrected. So I think this positivity needs to be transferred as physicians with the appropriate medical care and the surgical therapies.